Our first speaker this morning is Dr. Connor Peck. He is an orofacial pain and dental sleep medicine specialist at the TMJ Treatment Centers of Wisconsin. After finishing dental school at Marquette University, he came to the University of Minnesota Orofacial Pain Residency Program, which is where I had the pleasure of collaborating with him to provide multidisciplinary patient care. He was an exceptional resident, and he now continues his work in private practice. And he is here today to discuss initial management strategies for patients with orofacial pain. Please join me in welcoming Dr. Connor Peck.
Well, thank you, Emily, and thank you, everybody, for joining this program. Looking forward to getting to know some of you, hopefully this weekend, and hopefully we'll all learn a few things. So my topic that I was asked to speak about this weekend is initial management strategies in orofacial pain, self-care, and pharmacology. So when I first heard that this was my topic, it sounded pretty straightforward, and then I took a couple extra seconds to think about it and said, wow, this is very broad. So orofacial pain, as most of us know, covers a lot of different diagnoses, all with oftentimes with various treatment approaches. One may not work at all for another. So we'll try to, touch on different a number of the most common disorders and give you guys some key takeaways that you can take with you into your practice, while also going into some basic concepts that I think are applicable to a number of these, or to all of the disorders. So the objectives for the talk are going to be, number one, to define the goal of the first visit with an orofacial pain patient. And then again, go into kind of a high-level overview of some initial management strategies in patients with some of the most common disorders. These will include going into patient education, self-care strategies, home exercises, and obviously some of these are going to be more targeted for musculoskeletal pain disorders like TMD, and then pharmacologic approaches. So some basic reminders when we talk about initial management or setting the table, setting expectations with the patient, at that first visit. Number one is that accurate diagnosis is key, right? So if you have a patient who comes into the office and they've got right-sided jaw pain and you decide, this is TMD, I'm going to make them an appliance, I'm going to do injections, I'm going to prescribe a muscle relaxant, I'm going to get them into PT, you can do all of the right things from a TMD treatment strategy and initial management strategy. If the patient has an abscess in number 3 and that's where their pain's coming from, the patient's not going to get any better. So we need to listen to the patient, really emphasize taking a thorough history and taking your time with that exam. The first appointment, I think, in an orofacial pain practice, or when you've got an orofacial pain patient, particularly as they get more complex, that first visit and spending time with them, listening, is maybe more important than any other patient that you'll see in a dental office. Then I want to just briefly kind of explain my one concept that I learned when I was in my training was these bottom-up strategies versus top-down strategies. So I think it's a good way to conceptualize that first patient and when you're developing a treatment plan, how to set that in motion. So bottom-up strategies are things that you can do as the doctor to get the patient feeling better, whether that's getting them into an appliance. These are treatments you're offering to them: physical therapy, self-care, medications. It's sort of that biomedical model where what can you do as the doctor to help the patient? What can you give to them? And then top-down strategies are, okay, what can we do to help the patient better manage their disorder, their condition? And this kind of goes more into that biopsychosocial approach when we're talking about patients with high levels of stress, depression, post-traumatic stress. So we want to make sure we're not missing that part. So when you listen to the patient, you're not only letting them talk, but you're hearing what's worked for them, what's not worked for them, what's been tried, as far as treatment, and what maybe hasn't been given or offered to them yet. So if a patient comes in, and this is something that I'll see a lot as sort of a tertiary practice. They've already had an appliance made by their dentist. They've already been in physical therapy. They've already tried muscle medications, whatever the case, and nothing seems to be working. When we start thinking about initial management strategies, when you listen to that patient tell you what's been done and what hasn't worked, start thinking, okay, maybe there's something else that we can approach from a top-down strategy. Maybe this patient needs to get into health psychology, which I think we'll touch on a little bit today too. That's going to really inform, I think, your treatment recommendations as well. And then right after, of course, I say treatment, I want to emphasize the words management and treatment. So I think, in orofacial pain, especially like if I've got a patient with chronic TMD, I'm going to basically describe their condition to them as a chronic manageable condition. I think the word treatment has a connotation that you are going to fix their pain for them or that there's going to be a quick fix for their pain, while management basically, to me, has this connotation that this is something that you're going to work together with the patient to address over time. So really want to use that word management, I think, more often than treatment in most orofacial pain disorders. And then the goal of pain management. So this is variable depending on the disorder, but I think some research suggests that if you've got a chronic pain patient, chronic orofacial pain patient, a positive outcome might be a 50% or greater reduction in their pain. This is going to vary depending, again, on their disorder, but I think like when you spend time talking to a patient and you come to a diagnosis and you're laying it all out for the patient, understanding what their expectations are with treatment is really important because if the patient comes in and they've had pain, neuropathic pain, say for 20 plus years, overlapping chronic migraines, and they're finally getting in to see a specialist who knows what they're doing, and they think that now their pain's going to stop, that's unlikely to happen in most cases. So this is all part of that rapport building with the patient while also setting realistic expectations. And then that results take time. So this is something I think that separates an orofacial pain setting from, say, an endodontist office where a patient comes in with an infected pulp and you do a root canal and their pain's gone. This rarely, if ever, happens in a TMD or orofacial pain practice. So again, communicating with patients and setting realistic expectations and prognoses is really important. So this slide is really just kind of going into some general concepts and strategies for early management of an orofacial pain patient. So number one is patient education. So spending that time with the patient, whether they have trigeminal neuralgia, whether they have TMD, whether they have migraines, educating them on the pathophysiology of their disorder, letting them understand, too, that you're an expert, that you know what you're talking about, laying it out to them in lay terms so that you don't overwhelm the patient. And while you don't want to, be sinister and scare the patient, you do want to be honest with them. Some orofacial pain conditions have better prognoses than others, so you need to be honest. And then orofacial pain self-care. So I'm not sure how much we've gone into history taking, but one of the most important parts of the history for any orofacial pain patient is going to be asking about aggravating and alleviating factors. So what makes the pain worse? What makes the pain better? And so regardless of the diagnosis, again, whether this is TMD, whether this is a neuropathic pain, if you can identify those, not only is it going to lead you to the diagnosis, but it's going to really inform your early management strategies for that patient. So aggravating factors can be physical, they can be emotional. So you think of a TMD patient who may say that they wake up, their pain's worse in the morning from clenching their teeth at night. It's worse when they chew bagels, or it's it could be worse when they're under stress. It's worse when they're talking with their in-laws, something like that. So making sure that you're hearing them, and then you have that conversation with the patients, to help. Modify some of those factors as best you can. And then I think pain journaling is really important. So some patients you'll see, in an orofacial pain setting, they may not be very in tune with what makes their pain better, what makes it worse. Some can't even describe the quality, the duration, the frequency. And so you're sitting at them and your eyes are kind of glazing over, like, how am I going to help you if you don't even, you're not giving me anything, right? So it's not a case where you should be getting frustrated with the patient. It's one where, okay, let's take a step back, have the patient work with you to come to that conclusion. Sometimes we'll even have a patient come back in a month and say, hey, I want you to start to journal. I want you to tell me how often this pain comes, what does it feel like, what triggers it, what makes it feel better. And at that next visit, maybe and it usually does lead you at least closer to the conclusive diagnosis. So journaling is a really useful strategy. TMD. So obviously this is our kind of the bread and butter of an orofacial pain practice in most cases. This is what I'm sure many of you are here to learn more about this weekend. So we'll spend probably the majority of our talk talking about these before going into some other pharmacologic approaches. So TMD self-care, there's been some studies showing that this is about 40% of the reduction in pain. So if you're not spending time that first visit with a patient just educating them on self-care strategies, you're really doing a disservice to the patient. 40% is a huge number, and it can be equally, if not more effective than other TMD approaches independently. So that includes appliance therapy, physical therapy. Like if the patient isn't doing what they need to do at home from a self-care standpoint and modifying some of those aggravating factors that we just mentioned, I'd say their prognosis is far more guarded than it otherwise would be. And this is something that should really be discussed verbally and in writing at that first visit. So going into TMD self-care, the contents of that document, and if you guys don't have a document, feel free to shoot me an email at the email list on the title slide. I'm more than happy to kind of share some ideas as far as what ours looks like in our practice. TMD introduction. So again, this goes back to educating the patient. You want to define TMD to the patient. So a lot of patients come in. Obviously, they'll tell you I've got TMJ. You can. I wouldn't say correct them, but you can tell them that TMD is sort of a chronic It's an umbrella term that we use for pain or dysfunction in the jaw joints or the surrounding muscles. So you can be as simplistic as that. As far as discussing the etiology, based on the patient in the chair, you can kind of tailor that conversation to who you're working with and what that looks like. So, for instance, if you've got a patient who's a high school female, their jaw's clicking, popping, locking, they're a gymnast, you can talk about hypermobility, you can talk about genetics, right, playing a role as far as maybe that patient's condition. I like to kind of break it down as far as, in the majority of TMD cases, particularly when you've got, internal derangement and even muscle pain, you've got micro trauma, macro trauma, and genetics as typical causes or contributors to TMD. So micro trauma would be something as simple as, clenching, grinding the teeth, chewing gum, chronic overload of that jaw joint. Macro trauma, whiplash injury, blunt impact, falling on the chin. And then genetics would be something like hypermobility, patients who have maybe a rheumatologic condition where they've got arthritis in the jaw joint that's more systemic. And then pathophysiology, I found really helpful in my practice. We've got a couple images. They're artist illustrations of TMJs, some with normal disc position, closed mouth. We've got a normal disc position, open mouth. We've got disc displacements. We've got degenerative changes. And so, with that first visit with the patient, after you do your exam, take your history, you've got kind of a good idea as far as what's going on with their joints. And I think showing them in pictures that are, not too specific or not too scientific, but it can really be helpful as far as educating the patient. And you'll get a lot of head nods and a lot of buy-in from that. Massage. So self-care, massage is really, really common. It's something that you'll probably hear most of your patients have already tried. They tell you that, it hurts in the mass or it hurts in the temples. I massage it out. It seems to help it feel better. So this is something that, if they're not doing, you certainly want to encourage. You can also go a step further and give them some massage techniques that may be more something a physical therapist would do, especially if it takes a while to get the patient seen by a physical therapist. So, for instance, if I have a patient with significant masseter pain, which is very common, and they tell you that they rub it out if it hurts for a couple seconds and it seems to help, or maybe it doesn't, you can have them actually, teach them a bimanual massage technique where they get their thumb in there and they spend 5 minutes aside really massaging out that tissue. So you can have them step up their game a little bit, at that first visit. Heat or cold? So I'm sure most of us have been asked this question, what works best? The answer is, in my personal opinion, whatever feels the best to the patient. I think Generally, I think heat, for tight, tense muscles helps a little bit more, but I've got patients who find ice really helpful for that as well. I think an inflamed jaw joint, particularly a really acute case, an ice pack over the joint can go a long way. But, one, both, or alternating, I think is helpful. Teeth clenching. So, hopefully we've all heard of the tongue up, teeth apart position. So a lot of patients, again, don't understand that clenching is just when the teeth touch even lightly. So making them aware of that. You'll get a lot of patients who are, still in shock and awe when they hear you tell them that. So making sure, especially in times of increased stress, that they're, or maybe, ask them, when are you more likely to clench your jaw throughout the day? Because obviously there's only so much we can do to help them at nighttime, but if they can start to pay attention to that throughout the day, that goes a long way. Oral parafunction, so biting on pens, pencils, ice cubes, straws, lips, cheeks, fingernails. You kind of go through the list with patients, and you're often likely to find something that they're doing where they're overworking their jaw, and it's not serving them any nutritional value. So teeth clenching kind of falls into that basket as well. So identifying those habits when they're present and having the patient work to reduce them is really helpful. Caffeine. So I would be a hypocrite if I told all of my patients not to drink any coffee, because that is sort of my go-to. But caffeine is a muscle tensor. There's been evidence that says if you drink 2 cups of coffee a day, it's going to increase myofascial trigger points. Just for me, it's about making patients aware that caffeine is a tensor, generally going to promote tensing of the muscles, so that if they weren't paying attention to that, they can start to think about it, and oftentimes they'll cut back a little bit. Not only that, but it can also encourage rebound headaches too. So posture, both awake and sleep, there's a huge correlation between cervical issues and referred pain to the jaw. So making sure that patients are upright, they've got good posture, and you can tell when you're sitting across the table from a patient interviewing them whether or not posture is a likely issue. And then we've got this picture of this lady sleeping with her face on the sheets or on the pillow. Obviously, at night, we tend to want to reduce as much pressure to the lower jaw as possible. And then pharmacologic, so, in this as far as the Selfcare document, we're talking about analgesics, anti-inflammatories when helpful, and then we'll go into a little bit more detail later as far as what we can prescribe the patient. Proper diet, exercise, rest, and relaxation. So making sure that their overall wellness is up to par. And this kind of goes into that history and understanding who you're talking to, what their lifestyle is, what their work-life balance is, what kind of stressors they have in their life, and making sure that they're giving themselves time throughout the day to get some R&R. I was talking earlier this week to a patient because I had a back-to-back teachers, and I swear that in my practice, it's teachers and nurses are the numbers 1 and 2 in no specific order patients that we'll see. And the second poster I saw this morning, I don't know if anybody else saw it, but it was basically a study basically showing that teachers and nurses they seem to be the most common patients that you'll see. So, when you've got a nurse with a high stress, very active job, they're talking to patients throughout the day, making sure that they give themselves time to take some self-care throughout the day is key. And then reassurance. So, we want to make sure that we're again, being honest with the patient, but they need to know that this is likely, TMD, chronic manageable, likely not going to kill them, right? Very likely. In the majority of cases, this is not going to require any surgical treatment. There are obviously exceptions to that, but a lot of patients come in with clicking, the locking. They've got a severe pain that they've been dealing with for a long time, and their initial worry is, am I going to need surgery? And so being able to reassure patients that, generally speaking, a conservative multidisciplinary approach to treatment is all that they should need. So a little bit more self-care. We'll talk briefly about stretching exercises. So if patients have pain in the elevator muscles, so the elevator muscles are the muscles that bring the mandible up. So the temporalis, medial pterygoids, and masseters are the 3 main groups that we'll think of. I like a 3-finger stretch for these patients. I tell them 4 to 6 times a day. Take one fingertip, put it between your front teeth like this, rest your teeth on your fingertip, hold it there. It should be a mindfulness exercise. You should focus on feeling those muscles release. One fingertip should not feel like much. After 30 seconds, you add a second fingertip, give another 30, then see if you can go to 3. It should never cause pain. A lot of patients can't go to 3 right away, so you have them work towards it. But that I think, static hold to just get them paying attention to it works really well. And if you can have them do it, like I said, 4 to 6 times throughout the day, they're less likely, in my opinion, to let that stress and tension in the jaw manifest and continue to compound as the day goes on. And then we've got our lateral pterygoids. So, a lot of patients will have lateral pterygoid pain. A lot of times in our bruxers, or maybe patients after a prolonged dental appointment, they'll get pain back, in those deep structures. And so, this exercise that you see here, it's kind of a distraction-like approach where you're basically, and this is something the patient can do on their own. They're depressing the posterior, the lower molars on each side one at a time, and they're kind of working on pushing the condyle back to stretch out that muscle. Remember, the lateral pterygoid specifically, when that muscle fiber shortens and contracts, it's going to pull the condyle forward, so we want to let that condyle go back more. Now, this is not always a helpful exercise, so if you've got a patient with a lot of joint pain and inflammation, this is probably a contraindication because they're going to get a lot more pain from the joint. But if it's purely lateral pterygoid, this works really well, so 30 seconds times 6, and do that again 4 to 6 times a day. Bite tabs also work really well, so we've got these little sheets of basically rubber rectangles that we'll have, or you could use a tongue depressor, put them between the front teeth, tell the patient make it point down. When they do that, they'll feel the lower jaw kind of pulling back, protruding, and that's a good stretch for those muscles as well. And then we talked briefly about posture, or paying attention to that. So some exercises, if you've got a patient with forward head posture, they're slouched, they've got maybe neck pain also that you find during your exam refers up to the jaw. Chin tucks are good for neck strength and stability. They also help improve posture. Chest stretches are good for patients with or forward shoulders. Wall stretches are good for shoulder kind of stability and cervical alignment. The supine neck stretch, do this. You can do these last 2 in bed, or before bed. This is good for the deep flexors of the neck and also improving forward head posture. And then the prone arms lifts. Those are going to be good for patients with weaker shoulders or mid backs. So, just some things again that we're fortunate in my practice. We've got physical therapy. I think a good orofacial pain practice should either have it as part of the team or have a really good physical therapist in the area who you're able to refer to and work closely with, and who understands all of these structures well. But even in our own practice, sometimes it takes us 2 to 3 weeks to get a patient in to see the physical therapist. So if you can start that first visit giving them some of these exercises, that can be really helpful. And then habit reversal. So I mentioned, we've already touched on the pain diary. External cues, I think, work really well. So if patients are like, I clench my teeth, they come back, I'm like, I can't stop doing it. I every time I check in, I find that I'm doing it. You can tell them, okay, let's try, put a sticky note. You clench when you're driving, put a sticky note on your steering wheel. You clench when you're sending emails or working at a computer all day. Put a sticky note on your desk or on your computer that says sit upright, or stop clenching your teeth. It could be something silly too. Some patients will download a random timer app in their phone that'll vibrate periodically throughout the day, just kind of cueing them in, almost training themselves like a dog. So it's just about behavior modification. And then again, mini breaks. So talked about teachers and nurses. Those are the ones who I'll typically have this conversation with. You need to take time throughout the day for yourself, especially those people who, again, their focus is always external. They need to do some introspection. And then sometimes a daytime appliance can be useful for habit reversal as well. So tend to find lower stabilization or flat plane splints work well, just because they're easier to talk with if the patient does need to communicate. Now, obviously, it's still not going to be perfect. But a daytime appliance, as long as it's not a chew toy, I think works really well. I tell patients use this as a retraining tool, not as a crutch. But that's something that some patients find very effective. All right, so next we're going to talk a little bit about pharmacology. Again, very high level. I could probably, or maybe not me, but we could spend, an entire lecture on each class of medications here, but we just don't have the time. So we'll be we'll be kind of moving through here, but hopefully we'll touch on some key points. So considerations are obviously the type of pain. Is it musculoskeletal? Is it a headache disorder, tension type, migraine? Is it neuropathic pain? Is it neurovascular pain? So there's so many different medications. Many of these are off-label uses that you'll be able to use, or you should at least be aware of and have in your toolbox as an orofacial pain provider. So we'll kind of touch on some of the most important ones or the most commonly used ones today. Is the pain acute or chronic? So the majority of our acute pain patients, I would say, in an orofacial pain practice are going to be an acute TMD, maybe an acute migraine headache. A lot of these are, even TMD, oftentimes chronic pain. Some neuropathic pain conditions are chronic, so that's going to direct our treatment as well. What are the patient's preferences and expectations? Just anecdotally, I've seen more and more patients recently where I've started talking about medications and people seem a little bit resistant. They'd rather be treated holistically, and I'm totally on board with that in the majority of cases. There are some, unfortunately, orofacial pain conditions that really do require medications in most cases. And then also expectations. So, does the patient want their pain alleviated immediately, or do they expect their pain is going to be alleviated immediately, or is it something where they're willing to and open to trying a few medications until we find the right one? And then obviously their medical history. What medications have they tried? What's worked, what hasn't? What are contraindications, and so forth. So acute orofacial pain. So again, primarily musculoskeletal pain. Some of these can be useful for more acute headache conditions. These generally aren't meant for long-term use, but these are things that you can offer that first visit. So for more mild to moderate, anti-inflammatories, so ibuprofen 400 every 4 hours or so tends to work quite well. Naproxen sodium works well also, so Aleve can be a little tougher on the stomach, so I oftentimes start with ibuprofen if I can, but naproxen works really well too. Acetaminophen tends to work really well for patients with maybe more tension headaches that have been exacerbated, and again, try these for a couple weeks and see how the patient does. Again, these are medications, if you keep the patient on long term, are more likely to result in rebound or medication overuse headaches, so they can actually make the problem worse even though they seem to be helping initially. And then for more moderate to severe cases, tend to, oftentimes especially if this is a joint patient where there's acute inflammation in the jaw, we'll start with maybe a Medrol dose pack and then have them, once that's complete, follow up with a couple weeks of ibuprofen, really making sure we're taking care of all of that inflammation as best we can. So 800 when it's more severe every 8 hours works well. And then you can also take that in combination or alternating with ibuprofen. Acetaminophen with ibuprofen. And then I would say less commonly, Norco still works pretty well, especially in a really severe, maybe post-surgical case. Some neuropathic pain conditions, but exceedingly infrequently, I would say we'll need to go this route in an orofacial pain setting. So again, these are some of the kind of the workhorse medications most of us are familiar with. These are the protocols that I found effective. There are other, obviously, NSAIDs that work well. Sometimes meloxicam is a really good choice for certain patients. We could go all day, but I think this is a good initial protocol for that first visit, things to think about. And then for our chronic orofacial pain patients, so the first class we'll talk about are antidepressants. So we're all hopefully aware of SSRIs, so selective serotonin reuptake inhibitors. We know that serotonin plays a role in, or we believe it plays a role in depression, and those medications seem to work well. There's a newer class of medications called the SNRIs. So that basically they're inhibiting the reuptake of both serotonin and norepinephrine. Norepinephrine seems to play a role in pain. So these medications, while often useful in depression or depressed patients, they're really helpful in chronic pain patients as well, we found. So the earlier class, and I'm getting ahead of myself. So we'll talk about antidepressants in a second. But as far as the list goes of medications, we'll be running through the antidepressants. We'll talk about anticonvulsants, antihypertensives, some migraine medications, including this newer CGRP targeting drugs, and muscle relaxants and topicals. So back to antidepressants. The first, or I guess one of the earlier classes, are the tricyclic antidepressants. These are, in an orofacial pain practice, we're going to be using these at far lower doses than would be effective for depression. So these medications are amitriptyline and nortriptyline. There are a couple others, imipramine, that are also in this class. These are kind of the two, again, workhorse medications that we'll most commonly use. Amitriptyline pharmacologically is very, very similar to Flexeril, right? So if you've looked at the pharmacology at all, it's like one double carbon bond difference. So it works very similarly. You're going to prescribe these at bedtime generally because they are sedating. Some patients aren't sedated or aren't as sedated, and you can alter the timing in those cases. But these medications generally really effective for patients with chronic musculoskeletal pain. Can be useful for neuropathic pain conditions. So, an atypical facial pain patient, oftentimes even like an intraoral, like a PDAP type case, tend to respond to these medications if the patient can tolerate them. So the main drawback is that they do come with side effects, anticholinergic mainly. So like I said, they're sedating, hence the bedtime use. They can cause dry mouth, urinary retention and so forth. But they do work well. Duloxetine or Cymbalta. This is a medication that is also useful for patients with chronic musculoskeletal pain, some neuropathic pain conditions as well. Nice thing about duloxetine, it does have that efficacy for depression and anxiety too. So if you've got a patient with overlapping issues, maybe work with their primary care or their managing psychiatrist and consider this medication. And it is also analgesic at all doses, which the next one we'll talk about. So venlafaxine is, at 37.5 milligrams, you're probably not getting a lot of analgesia, so you really have to up the dose for it to be truly effective. The nice thing about duloxetine and venlafaxine is that while they act as serotonin and norepinephrine reuptake inhibitors, like the TCAs, they don't have the anticholinergic side effects, so they're generally better tolerated, I would say, by most patients. So venlafaxine is used for migraine prophylaxis, tension headaches, neuropathic pain, and can also be useful in some atypical facial pain cases as sort of maybe a second line, third line. So the next category we'll go into are the anticonvulsants. So carbamazepine or Tegretol, I'm sure many of us have heard of. Trigeminal neuralgia is, one of the kind of the buzz orofacial pain diagnoses. At least where I live, I still often see it misdiagnosed by general dentists, but almost more so by primary care doctors. So I've got a lot of patients coming in on this medication when it doesn't seem to be truly the accurate diagnosis, but it's something that we should be aware of because if it is a true TN case, this is still kind of the gold standard treatment. So these work by basically stabilizing hyperexcitable sodium channels. They're generally prescribed 100 milligrams twice daily. Now, with it, a lot of side effects, so you definitely want to get a CBC typically before prescribing it, as well as some liver function tests, and probably repeating those 2 to 3 weeks after prescribing them as well. But it does generally, it's almost diagnostic. If the patient, if you feel that they have TN or some sort of a paroxysmal neuropathic pain and they respond wholly to carbamazepine, it's almost conclusive that you have the right diagnosis. Oxcarbazepine is basically, it's pharmacologically very similar to carbamazepine, just a different metabolism, so it's generally got less side effects associated with it, still works by stabilizing sodium channels. Works really well, again, primarily for those paroxysmal neuropathic pains like neuralgias. Doesn't require the pre-treatment labs, but generally can be associated with low sodium levels or hyponatremia. So you'll want to take tests for that some point in treatment, probably a few months in. Gabapentin and pregabalin, I'll kind of lump these together. These are the two in this group that don't primarily work on sodium channels, so these are more the calcium channel blockers. Gabapentin's been used for many years, sort of the wonder drug, works for a number of chronic pain conditions, whether it's musculoskeletal, works for migraines. It's still, I think, a first line for trigeminal neuralgia, sort of like the first two we talked about. And other more chronic continuous neuropathic pain conditions, I would say more so than the first two, would respond likely to gabapentin and pregabalin. So these are important medications to be aware of. Topiramate or Topamax is one of the kind of first-line migraine prophylactic medications. So if you've got a patient in the chair with, your diagnosis is migraine, this is something that you can start them on. Also generally works primarily, we believe, by being a sodium channel blocker. And then we have lamotrigine, very similar to carbamazepine, kind of a second line for trigeminal neuralgia, also useful for some of the more rare headache disorders like Sunct and Suna. And then finally, clonazepam. So this is the one benzodiazepine that's been approved for seizures. So this is why it kind of fits into this category. This is one where, it can be very difficult to get off of once you've started a patient on it. So that's something to be mindful of, generally taken at bedtime due to its sedating effects. Sometimes useful for chronic musculoskeletal pain, especially if a patient hasn't already responded to like a TCA that you've tried first. And also, something to be aware of if you're suspecting burning mouth syndrome. This is a medication that's probably got the most efficacy in that unfortunate condition. So the antihypertensives, we'll just touch on two of them. Propranolol is a migraine prophylactic medication, sort of like topiramate, another first-line treatment that you can try. It's a non-selective beta blocker. And then verapamil is going to be a calcium channel antagonist, and this would be second line for migraines, but first line for an acute cluster headache patient. I wish I could make this part more fun for everybody, but just wanted to kind of buzz through it, and hopefully we're learning something at least. So triptans, so now we're talking more migraine treatments. So the triptans have been around since the early 90s. They work basically by being agonists for two specific subsets of serotonin receptors, 1B and 1D. There's a number of them, so I think I'm going to list 8. I believe that's all of them. Definitely not going to be testing you guys on these, but these are used for acute migraines. They generally are going to be, you're going to want to take them as early into the headache as possible, and if the headache persists after 2 hours, generally you can repeat your dose at that point. Something that you're not going to want to take more than about 10, 11 times per month, ideally, because they can result in rebound headaches. And these are very effective, but they're going to be contraindicated in patients with a history of cardiovascular disease, just because they're sort of vasoconstrictors, and so some patients will report chest tightness and other unfortunate side effects with them. But when tolerated, they generally work really, really well. So the newer class here is called the ditans. So this is another migraine medication that's useful for acute migraines and also acts on serotonin, but at different receptors. This is acting as an agonist of the 1F receptor. The medication is called Rayvow. I believe it's only 2 or 3 years old now. It is a controlled substance. It's more sedating than the other two, so there's actually an 8-hour driving restriction once you've taken it. But because it's acting on a different receptor, it doesn't have the same vasoconstrictive properties as the triptans do. So if you've got a patient who you'd like to prescribe a triptan, but they've had a stroke or they've got peripheral artery disease, then you can try a ditan, if they're suitable candidates. I believe Rayvow, I could be mistaken, I believe this is the only one right now. So the CGRP medications, the monoclonal antibodies, and the GPANTs. Number one, so Aimovig, Ajovy, and Emgality, these have been around since about 2018. These are basically monthly injections that your patients will take. This is useful for both chronic migraines as well as episodic migraines. Generally work really, really well. So CGRP, for those who don't know, is basically a protein that's released by the trigeminal vascular system. That's especially during a migraine attack, it's been found to be a really critical component of that pain. So by targeting that peptide specifically, these medications have been really, really effective and kind of game changers in recent years. So the newer ones are the G-pants. So these are nice because they're more like the triptans, where you can take, some of them anyways, you can take them for an acute migraine as opposed to having to do a monthly injection. So Ubrelvy, you may have seen Serena Williams advertise for this one. She's a big Ubrelvy supporter. This is one where you can take it, I believe Ubrelvy, forgive me. So some of these are take as needed. Like when you get a migraine, and some of them are more that you can take prophylactically. Nurtec is an oral disintegrating tablet, and Qulipta. So Qulipta is the one where you can take it once daily. Ubrelvy you would take sort of like a triptan, where you take it at the start of a migraine attack, and then you can take another one 2 hours later if needed. And then I believe Nurtec is one where you can do one of each. You could either take it for acute migraines, or you can take it prophylactically. You just do that every other day, whereas the Qulipta would be an everyday medication. And then the latest one, this was just approved about 2 months ago or less than. This is the first G-pant that's used as a nasal spray. So Zavegepant, I believe. I'm not sure how to pronounce that one, but this is the latest G-pant. So then the muscle relaxants, cyclobenzaprine, Flexeril. Hopefully we've all heard of this one. Works quite well. Typically taken at bedtime. Oftentimes, especially if patients say that they're sensitive to medications, I'll encourage them to maybe start by breaking it in half, or even prescribe a 5 milligram tablet. And then they can up it to 10 if needed. Generally not something that we'll want to keep patients on super long term, just because there's not a terrific amount of evidence for that. But I do have patients who've been on it for longer periods. I'll typically start a patient, like a TMD patient, where I want to prescribe a muscle relaxant. I'll prescribe it for about a month and kind of see how things go. Baclofen is another one that can be used independently as a muscle relaxant. But it can also be used as an adjunct in patients with like a trigeminal neuralgia. If they're having issues tolerating higher doses of carbamazepine, you can supplement that with baclofen so that they generally get a good response at a lower level of the anticonvulsant. Tizanidine, so this is an alpha adrenergic agonist. It's basically useful, I think, in patients where they would prefer to take a muscle relaxant throughout the day. Flexeril is too sedating for them. These generally work really well in chronic musculoskeletal pain, tension headaches. I found especially helpful. So typically start them at 2 milligrams 3 times daily, and then you can up it pretty significantly up to like 36 milligrams a day total as needed. And then diazepam, another bedtime medication. So this is one that's going to help the patient sleep. And if they've got overlapping anxiety, it can work quite well. And then Botox. So the first 4 are all more like centrally acting muscle relaxants. Botox would be the peripheral one. So this is, we don't have to spend a ton of time on it, but, and obviously as far as early or initial management, this isn't something you're doing day one, but it's still certainly something you want to make the patient aware of, that would be an option for them. These work really well, I'd say, in an orofacial pain practice, either for, your chronic migraine patients, your patients who are heavy bruxers. They come in with masseter hypertrophy, temporalis hypertrophy. They've already tried and failed other treatments. Oftentimes we'll offer this to them, and I've had some really good results with it. There's a few different types of Botox medications, out there right now. Some are, or botulinum toxins, I should say. Some are more affordable than others, and generally they all work very comparably in my experience. And then there's the topicals. So anesthetics, so you've got local lidocaine. For, this picture, the patient may have some persistent dental alveolar pain, and they've made a medication stent. And you can do this every 3 to 4 hours, sort of as needed for patients with that chronic continuous neuropathic pain. You can also do an extraoral patch. Some of these are available over the counter too, if you go over to Walgreens or CVS. And then Emla cream is another one. So if a patient has, neuropathic pain somewhere on the skin, they can apply this topically. This is, I think, Emla is the eucalyptic mix of local anesthetics. So it's local. It's lidocaine and prilocaine combined. And then we've got topical NSAIDs. So patients who may not tolerate ibuprofen or another NSAID because of GI issues or something else. but they've got acute TMJ pain and you want to give them something that first visit that can help calm things down. I found that diclofenac works fairly well for these patients. Just want to make sure that they wash their hands afterwards and don't start, poking their eye. But this is something that you can prescribe to them. It's also available at the drugstore. Just put a pea-sized amount on the finger, rub it over the joint. And the evidence actually suggests it works pretty comparably to something taken orally. And then capsaicin. So capsaicin is the active component in chili peppers. So it's very hot. It's kind of interesting. You're inflicting pain as a means to ultimately down the road reduce pain. But capsaicin can be used both extraorally or intraorally in patients with neuropathic pain, patients who have chronic muscle pain, joint pain. There's a lot of applications to this. If a patient can tolerate it, it's not super fun. You have to generally do it for about a month or so for it to fully take effect. But you're basically just depleting substance P, which is a pro-nociceptive transmitter or protein, but generally works really well. So that's my talk. I don't know if we're doing questions now or afterwards. The Q&A. Okay, awesome. Well, thank you guys for your time.